Hi, my name's Joe Bellick, and I'm the founding partner of the law offices of Bellick and Fox. We support the mesothelioma community by providing first-quality legal representation to mesothelioma patients and their families. During these troubling times, we're proud to support the Mesothelioma Applied Research Foundation so they can continue the work that they do every day on behalf of mesothelioma patients and their families.
My name is Kelly Batley.
My name is Clay Thompson.
My name is Neil Mowney.
We are MRHFM, a national firm with 70 attorneys and 11 offices across the U.S.
At MRHFM, we exclusively help mesothelioma patients and their families. It's all we do.
This is why we are proud to sponsor the Mesothelioma Applied Research Foundation and its work to fund mesothelioma research and provide support services and education for patients and their families.
At NovaCure, we strive to extend survival in some of the most aggressive forms of cancer through the development and commercialization of our innovative therapy called Tumor Treating Fields. NovaCure is pleased to partner again with the Meso Foundation.
Good afternoon, Dr. Johnson. Thank you so much for joining us for our latest episode of MesoTV.
Hi, Mary. Thanks for having me. Glad to be here.
Thank you. Thanks. So, Dr. Johnson, you're not at what we would consider to be, a typical mesothelioma center. So, could you talk a little bit about, your position and where you're located, and a little bit about, the philosophy of where you work?
Sure. Mary, I'm the director of the lung cancer research program at the Sarah Cannon Research Institute in Nashville, Tennessee. Sarah Cannon is a physician-based research network that's based in the community. And so our mission at Sarah Cannon is to provide access to cutting-edge therapies to patients in the communities in which they live. So we take it very seriously that we would have offerings so that patients wouldn't have to travel to tertiary referral centers. Now, for something like mesothelioma, where the care for which is obviously multidisciplinary, where a surgeon with experience in caring for mesothelioma is critical, it's a challenge, right? But not patients with mesothelioma will not always need surgery. They will come to points in their care where they need a systemic therapy beyond chemotherapy and maybe immune therapy. And that's when patients should seek out a place like Sarah Cannon.
Mm-hmm. So traditionally, from what I remember over the years, you do tend to run mesothelioma clinical trials. You usually have, some specific for mesothelioma, as well as having a very robust phase 1 study group there as well.
Yep, that's right. I'm a thoracic oncologist by training. Did my training at Sloan Kettering with the group there, and consider myself a thoracic oncologist today, although I see a little bit of lots of cancers. Day to day, I see patients in our drug development unit here in Nashville, and we have over 100 trials ongoing and active at any one time. We enrolled patients to over 500 trials in 2020 despite COVID. And so there are options for all types of cancer, including patients with mesothelioma. The more traditional therapy, once every 3 weeks by IV infusion or an oral therapy, those will always be available. But some of the options that I'm most excited about, in particular for the mesothelioma patient population right now, are immune effector cell trials or CAR T cell trials that are trying to harness a patient's immune system in a novel way.
Wonderful. So I think, the basis of our talk today actually falls beautifully into that. We're going to be discussing TC-210, which I understand is a multi-center trial. It's being done at different centers around the United States. And I know that you've taken care of quite a few patients in our groups, and you and I have met at some of the meetings, and I'm really excited to hear from you about this TC-210. What is a CAR T-cell trial? How are they developed? What is it?
Well, thanks for the opportunity, Mary, to talk about this topic. CAR T-cell, CAR stands for chimeric antigen receptor. And the way that you can understand that is that these are white blood cells that have been removed from a patient. And I like to tell my patients they've been educated or instructed to begin to recognize aspects of the mesothelioma cancer that they didn't know existed before. And once these T cells have been educated with the introduction of a CAR receptor, then they're put back into the patient. And they set up shop there, and they're able to then help the patient's immune system begin to recognize the cancer. Now let's talk about TC-210. This is actually a T cell receptor fusion construct, or a TRuC, that works by similar principles to a CAR T cell therapy. It's even a play on words a little bit, in that the white blood cells, the T cells, are removed from the patient, engineered to express the receptor that identifies mesothelin in the cancer cells, put back into the patient's bloodstream and affords the opportunity for the patient's immune system to begin to recognize the mesothelin that is typically expressed on mesothelioma cells.
So how do you get these cells out of a patient's body?
Good question. It's actually very easy. We use a reverse blood cell transfusion called an apheresis. In order to do it efficiently, if you think about how long a blood cell transfusion takes to get into your body, or a blood cell donation to get out of your body, the same is true. The same technology is used, only we use a bigger IV. An apheresis catheter resembles a dialysis catheter. We put it in the morning that the cells are to be removed, and then it takes about 4 hours to remove the blood. From that, the white blood cells can be isolated, and those are the cells that are then frozen down and shipped to the lab to begin the process of learning to recognize the mesothelin receptor.
So now that you've taken our white blood cells, are we at risk for increased infections? Are there anything that we have to worry about when you've taken these cells out?
Good question. The process of the apheresis, or the reverse blood cell transfusion, is pretty safe. Believe it or not, you have many fold more red blood cells and white blood cells left than the couple pints of blood that we take. So right after the procedure, patients are not at any increased risk for infection. They're not at increased risk for anemia, for example. However, in order to put those white blood cells back into the patient, we need to tamp down the rest of a patient's immune system so that the engineered white blood cells can, I say, set up shop. But we certainly wouldn't want a patient's immune system to attack these newly engineered white blood cells and sort of get rid of the very cells that we've worked so hard to make. And so in order to do that, patients do have to undergo usually 3 or 4 days of chemotherapy prior to receiving their own T cells back. After that process, patients are at what we would call immunosuppressed, because the chemotherapy has suppressed the immune system temporarily so that the engineered white blood cells can be replaced.
Mm-hmm. So how long a period of time? So now you've taken the blood, you're re-engineering it, you give them a conditioning regimen, which is chemotherapy, but probably at a lower dose than standard chemotherapy. During that period of time when they're most at risk, are they at home? Are they at the hospital? Where are patients during this period of time?
Good questions. And Mary, I just want to point out that between the time when the reverse blood cell transfusion happens and the point at which patients get their T cells back and maybe undergo lymphodepletive chemotherapy first, that period can be 2 or 3 months. That's the time it takes to manufacture those T cells. And so each clinical trial is different about what therapies are or are not allowed during that time period. In particular, and so it's important to talk to your doctor about the time, that 8-12 week time period. What would happen if you were off therapy completely, or what would happen if you were on pembrolizumab, for example, or chemotherapy as another example. So that waiting period is an important time period to understand. But your question was, once patients receive the lymphodepletive chemotherapy, where are they, and for how long are they at risk? It's a good question. Actually, the chemotherapy that's given is fludarabine and cyclophosphamide, and the function, it really is to suppress the lymphocytes in particular. And the lymphocytes stay down for about 2.5, 3 weeks, sometimes longer. Sometimes patients will also have anemias or thrombocytopenia, low platelets, during that 3, sometimes 4-week time period right after the chemotherapy. Directly after the lymphodepletive chemotherapy, patients at my center are admitted to the hospital 2 days after they finish the chemotherapy to get their T cells. The T cell infusion is actually a very it's actually a very easy process. Our nurses are very accustomed to doing it, but it is the chance of what we call cytokine release syndrome that is the reason that patients are admitted and are followed for a couple days with vital signs. We're looking for fevers. We're looking for low blood pressure. We're looking for any decreased oxygen level or oxygen counts. And those are signs that the immune system actually has become activated. So just because you have these things, it's not an adverse event. It's actually expected, but we want you in a controlled place in order to receive that therapy. If all goes well, then that's when you leave the hospital, actually. And we ask that you stay close within half an hour. Many patients actually stay at a hotel near the center for the first month in order to ensure that you could get to the doctor, to me, to the clinic, to the hospital quickly if you would start to have an infection. It is that period of about a month until your white blood cells go back to normal that patients are at risk for infections.
Okay, so they come to you for a consultation, sign a consent form, you collect, you collect their bloods, then they go back to their home, to their home port, discuss with their medical oncologist whether it's safe to be off of treatment for those 3 months, or whether they would, continue on with some sort of chemotherapy while we're waiting for the advent of this trial.
Yes.
They come back to you, they get the conditioning regimen, they get the cells reinfused in the hospital a few days, and then to be in the area for about a month. Now, do you have a Hope Lodge, or do you have relationships with hotels in the area? These are always, the costs, the patients need to factor in.
Absolutely. And the answer is yes, we have a Hope Lodge. And yes, there are hotels in the area. I have to say that even during COVID, we have taken care of patients on this and other CAR T cell trials. And so, in fact, when many centers across the country were closed because of COVID, patients came to Sarah Cannon to participate in clinical research because we were able to stay open. Many patients during the last year have voiced concern about needing to go into the hospital to get their T cells during, I don't want to go to the hospital, Dr. Johnson, because of COVID. But we have developed a very clear process for having patients that are immunosuppressed go through the emergency room and the clinic on a completely different track than any patient that might have a suspected COVID infection. And that has kept us safe. We have, knock wood, through 2 spikes in our area, continued to treat patients with these therapies. And I think it's a testament to what can be done with collaboration and communication across outpatient and inpatient teams.
Now, how about health insurance? Does health insurance cover these type of treatments?
Good question. In general, at Sarah Cannon, that's a question that is on everybody's mind as they come to see us for an opinion. And while there are some exceptions when it comes to Medicare in different states not wanting patients to come to Tennessee for treatment, in general, all of these therapies are paid for with a combination of private insurance and the sponsor's supportive research grants. Now, for patients, this is something that we typically try to establish before a patient would come down to Nashville to be treated. And typically by the time I meet a patient, our billing office has confirmed that their insurance will pay. For the most part, this is what I tell patients. We will bill your insurance for everything that is standard of care. And that is all the things that your home primary oncologist is billing your insurance for. So the lab visits, the doctor's visits, the CT scans, those are paid for by your insurance for your primary oncology care, and they're paid for by your insurance on a clinical trial. Anything that is specific to the trial, to include the therapy itself, is paid by the drug company that's sponsoring the trial. And so obviously the
I'm sure that's a relief.
initial hospitalization, for example, that is required by the trial is typically a research expense.
Wonderful. So it mainly is covered. Anything that's standard generalized care is covered by insurance, and then the extras are picked up by the sponsoring company that for the trial. So in terms of the Hope Lodge provides free housing for patients with cancer in general. And I just wanted to make sure that people who are listening understand that you cannot book directly with Hope Lodge. The bookings go through the social work, nursing, physician's offices where you're being treated. So that's something that arrangements that will be made, at the time of consultation. And if there's no room at the lodge, certainly the foundation also has a travel grant program. So, we can help with the cost of getting to a treatment. We can help with the hotel bills. We do have limitations, and we do ask that people demonstrate financial need, but we have been able to help a great many of the patients, get through these trials.
Miriam,
something that we didn't, yes.
I might just add to that, we've talked some about the Hope Lodge, and that for many patients that are being treated on these immune effector cell therapies, as well as bone marrow transplants, the Hope Lodge is vital because they need to stay close to the hospital for a month. And but because Sarah Cannon is a destination for people in the Southeast and the Midwest for all sorts of clinical trials, we also have a number of relationships with hotels right around the center that even offer shuttle service to the hospital, every day. They'll come get you when you're done, but also a little bit away from the facility that would also obviously be a little bit more cost effective. If you have a car and can drive and you can stay 30 miles outside of Nashville, then that affords even, I think, probably a more cost effective way There are a lot of options. Many clinical trial companies are also willing to offset the costs of staying locally because they understand that it's because of the clinical trial that you're not driving home that night, but staying for 3 days for blood work, for example. So there are many times where we're able to offer assistance as well. And I just encourage upfront communication about your needs, just as Mary was outlining, because we can figure out how to pool resources to help.
Right. I mean, these are just the factors that sometimes, people don't think about, working with your post office to have your mail held for that month. Just so many little pieces that, really take, you really have to plan and really take a careful, recap of what goes on in a month in your own home, that you can make sure those needs are addressed. Now, what we didn't discuss is this trial for both pleural and peritoneal mesothelioma.
That's a good question. It is. Both pleural and peritoneal mesothelioma qualify. What does need to happen, and there has been a learning curve associated with this, is for many of our patients, is that patients have to provide tissue within the last year to be tested at TCR squared for mesothelin expression. And while many patients have come to me from all over the country and have said, oh, I know that my tumor expresses mesothelin, it did at the time of my biopsy, or it did at the time of my initial resection, for example. With chemotherapy and even with immune therapy, we have found that mesothelin expression can go down or go away. And we don't have a whole lot of insight as to the amount of mesothelin expression that's required because the testing is done at the TCR squared laboratories. But my sense is that the bar is pretty high. Because we've had patients not qualify for this trial in particular because of that, and so that's an important thing to know coming to visit for the first time.
So the type of patient then you would be taking epithelial mesothelioma and biphasic that have a certain percentage of epithelial cells.
I think there is a limitation to the amount of sarcomatoid mesothelioma that is still eligible. It certainly needs to be the minority of the cancer.
Okay, and then now with we've just recently had the Ipi-Nivo approved, so now you're seeing many more patients who already had chemo, have had immunotherapy. Are they disqualified from your trial if they've had prior immunotherapy?
No, not at all. Patients have been, I've been seeing patients who have been treated previously with pembrolizumab for years. And so now the paradigm is shifting, right? Because patients will have had immunotherapy and maybe not chemotherapy when they come.
Yes.
But of course, chemotherapy is a good bridge while you're waiting for your T cells, for example. I believe that's allowed. And so it isn't exclusionary because, of course, while checkpoint inhibition improves survival for patients with mesothelioma, it's not curing anybody. And so we need to continue finding other ways to harness the immune system for patients. This trial
Thank you. So I guess probably one of my last questions would be, how are the patients managed post the infusion? How often are they scanned? What are you looking for in terms of response?
Yeah, that's a good question. I think it is, we are guilty at Sarah Cannon also of thinking about it as an afterthought, because of course, once you treat these patients, the advantage of any CAR T-cell therapy is that it's a one-time treatment as opposed to once every 3 weeks. And so you could envision, oh yeah, I can go home and I can go about my life. And that is true after a month for certain. But there are repeat scans starting at about 6 weeks with a CT scan, and then a CT and a PET scan at week 12 or around 3 months of therapy. It is interesting to me that we have had patients whose cancer burden on CT scan didn't change very much, although the avidity on their PET scan did. And so it has shown me that, yet again, the radiographic measurements of response that we use, i.e. CT scan, may not be completely accurate for measuring the immune response to tumor. And so we follow, as a result, with both CT and PET, intermittent or CT and then CT and PET. And I prefer that those scans are done here only because then we have a really good comparison one to the other. Now, in 2020, I mean, you couldn't make it up how many different challenges we had for that. COVID-19, obviously, but also tornadoes and hurricanes, that flooding that prohibited patients from getting scans, COVID that prevented patients from traveling. So we've done the very best we can. I think in the future, things will get easier. But it is only with that repeat disease assessment that we start to understand whether the cancer is controlled or not. What some of my patients have described, even after their treatment, is just this fatigue and flu-y feeling that we wonder if it is related to, an ongoing anti-cancer immune response. So there's more work that needs to be done to understand that, and exactly what the side effect profile is from a successful treatment with a CAR or TRuC in this case.
Yes, in fact, I was just speaking to a patient about this yesterday, not from your trial, but with another immunotherapy combination. And I explained that some of the early work that had been done was done actually in melanoma, looking at interferon. And they showed that, daily exercise, a regimen of on the treadmill every day really helped to overcome the fatigue. So there is a way to sort of work through this a little bit differently than you would try to work through, the chemotherapy related to fatigue. You really have to sleep it off. But with immunotherapy, it seems that activity actually helps to give that better, sense of well-being and get people on their feet a little quicker.
Oh, that's interesting. That certainly has been our experience as well. And, just underscores how much there is to know.
All right. And then just one more question about PET scans, because I know many of the patients, some of their insurances give them a really hard time about a PET scan. So if that's the case, they would come to your institute and the PET scan would get covered, or?
Well, that's right. That's a good example of a research required test that will be billed to insurance. If insurance won't pay, then the study is asking for that PET scan to be done, and they have paid. We've done all sorts of things this year to reimburse patients for getting PET scans who couldn't get to Sarah Cannon in Nashville to have it performed. So, I think I have found TCR squared to be very receptive and responsive, and just they have been realistic about the challenges that patients face in the post-COVID world that we live in.
Yeah, it's been tough. Now, just how are you advising your patients in terms of the COVID the vaccine? Is there any timing that we worry about getting your treatment in terms of when they should have the vaccine?
Well, I think the short answer is we don't know. We're learning as we go. I guess my second short answer is I am encouraging all of my patients to be vaccinated. The challenging piece is the timing with respect to patients' treatment, because if patients are undergoing immunosuppressive chemotherapy, or, for example, a lymphodepletive regimen prior to a T-cell infusion, that wouldn't be the time to get a vaccine. So there is some challenge, and I call it a dance. You might not be able to get everything all at once, but hopefully in 3 months we'll get it all in. Because of course, patients with mesothelioma or lung cancer are at risk of contracting COVID-19.
Right. So I guess probably the best advice we would give at this point is that if you have the opportunity to get the vaccine, get it before you embark on perhaps a treatment that's going to, maybe tamp down the response you'd expect or hope to get from this vaccine. So, yeah.
I agree.
Dr. Johnson, thank you. So thank you so much. I think this was a really good discussion about, about this program. And I just wondered, is there anything else that you'd like to tell us about, any other work that you're doing in mesothelioma? Any other trials that you think patients may be interested in? And, we could schedule another call to go into them in, more depth, but anything that should be on our radar.
I have to say, I'm so glad to hear that immune effector cell therapy is on your radar, Mary, and on the radar for the Mesothelioma Foundation. I think there is something special about this sort of treatment for patients with mesothelioma vis-a-vis lung cancer, where I would say the traction hasn't been as good. We're involved in treatment of lung cancer patients in some of these trials as well, and it is more difficult for a variety of reasons. Perhaps it is because of the antigen of interest. In this case, mesothelin WT1 is another highly expressed on mesothelioma, but not on most normal cells, where there are a lot of antigens that are being investigated to engineer T cells to recognize on lung cancers that are also expressed on regular tissue. That increases the risk of on-target, off-tumor side effects. I think we have other CAR T cell options coming, as well as vaccine options that are coming for patients with mesothelioma. And I'd be happy to talk about those with you next time.
Wonderful. So thank you so much, and thank you for giving us this time today. I'm very much looking forward to seeing, some of the results from this trial, and certainly encouraging patients. I think we always need to think of clinical trials as an opportunity. They didn't emerge out of thin air. There's a lot of good science, solid work behind them, and in a rare disease, I think, travel opportunities, you have to grab them when they exist.
At Sarah Cannon, we like to say that clinical trials should be your first option, not your last.
Well, thank you, and stay safe, and we'll be in touch with you. Thanks again. This was wonderful to have an opportunity to reconnect with you.
Thanks
Thank
for the
you.
opportunity, Mary.
You're welcome. Bye-bye.
Bye.